Hi, my name's Richard Hurley, BMJ's Features and Debate Editor. Welcome to this panel discussion. Is there a doctor in the house? The BMJ has been covering the medical cannabis developments over the past few years. In 2018, in the UK, we saw high-profile cases of young children with otherwise untreatable epilepsies finding that their symptoms were hugely reduced by taking natural cannabis products that they were buying or their parents were buying abroad. And after huge media attention, the government rescheduled cannabis products into Schedule 2 of the misuse of drugs regulations to recognise that they had medical benefit, that cannabis could have medical benefit, and so it could be prescribed by doctors. The NHS then created rules for prescribing, and professional associations like the Royal College of Physicians and the British Paediatric Neurology Association issued evidence-based guidance on prescribing. Yet today, as far as I understand, the number of NHS patients receiving full spectrum cannabis plant products you can count on your fingers. But meanwhile, commercial cannabis clinics seem to be blooming, but also charging patients huge sums of money a month for access to what I understand are unlicensed and perhaps under-researched treatments, and in all kinds of indications, including pain and psychiatric conditions. There's huge commercial interest in medical cannabis. Predictions of a market seem to be worth billions, and simultaneously burgeoning market in wellness, cannabinoids for people who are healthy, the so-called wellness market. And of course, there's also some industry players also interested in recreational cannabis market worth even more. So cannabis clearly has medical use, but the question is, how can we make sure the right patients get access to the right treatments? And I'm joined today by some experts in this very topic. Professor Mike Barnes is Honorary Professor of Neurological Rehabilitation at Newcastle University. Dr. Rebecca Moore is a psychiatrist and cannabis prescribing doctor at a private cannabis clinic. And Bradley Moore is the CEO of Global Cannabis Application Corporation. So perhaps, Rebecca, would you mind explaining what's happened for patients since the law changed in the UK?
So, I mean, I can speak of my experience of that, which is I work in one of the private medical cannabis clinics, and as you said, seeing an increasing number of people presenting wanting to be assessed for whether they would be prescribed medicinal cannabis for a wide range of diagnoses, and certainly, you know, seen an explosion of people interested in coming for a consultation, and as a clinician, seen, you know, a huge amount of people find this life-changing in terms of treatment and results. But clearly, you know, in terms of an NHS pathway, it's not yet something that I, as a consultant, although I've tried, can, you know, readily get colleagues to prescribe via an NHS route. So it does remain something that is expensive and thus prohibits some people from accessing it.
And what kind of indications are you prescribing for? Is it all psychiatric indications in your clinic?
It is for me, because obviously that's my expertise. So, you know, PTSD, depression, ADHD, anxiety, insomnia, fibromyalgia are all conditions which can really be helped enormously with a careful prescription. But then I also have colleagues who are gastroenterologists, pain specialists in oncology, so a huge, you know, different array of reasons why people might be coming for a consultation.
And Mike, would you like to talk to this as well? What's your view on what's happened since the law changed in 2018 for patients?
Well, yeah, I thought 1st November 2018 was potentially an excellent day because with a media campaign that was successful, the law was changed. But that's sadly not shown to be the case in reality. And as you said earlier, to the best of my knowledge, there's only 3 National Health Service prescriptions written, all for children, and none for adults. And there's no legal reason why NHS doctors can't prescribe. They're perfectly entitled to prescribe. So sadly, in many ways, the 6,000, I think, is roughly the number at the moment who've been prescribed privately. Now, the costs privately are coming down. They're about half of what they were when this started about a year ago. But nevertheless, that still makes them very expensive for many people. In fact, out of the question for many people. Even though the costs are now roughly £5 or £6 a gram of cannabis, about £7.50 a gram, which is a reasonable price. But nevertheless, if the NHS was prescribing in bulk volume, as there should be the case, then the cost would presumably come down much more affordable. But that's not the case at the moment. Why isn't it at the moment? And I think it's largely because of the very negative guidelines produced by NICE and by other bodies, including the British Paediatric Neurology Association, which I'm afraid I don't agree with at all. There are more realistic, sensible, balanced guidelines. I would say that, wouldn't I, Richard? But from the Medical Cannabis Clinicians Society. But nevertheless, there are guidelines around, but some doctors in the NHS are wanting to prescribe. Some are stopped from doing so by those guidelines. Some are prevented from doing so by their hospital hierarchy, who don't want to go against NICE guidelines, for example. And we've had recently one case that's got through the internal NHS. The consultant wants to prescribe. The trust has said, yes, you can prescribe. It's gone to NHS England for a funding approval, and it's been stopped at NHS England. So so if you want a prescription on NHS, you've got to get through 3 barriers: your NHS consultant, your NHS hospital hierarchy, because it's only hospital consultants at the moment that can initiate prescription, and then finally NHS England to approve the funding. Despite Matt Hancock publicly saying he would make sure that there was no barrier to cannabis prescription on the grounds of cost, the NHS England has just refused something on the grounds of cost. So there's a long way we need to go yet to get the numbers prescribed. And if you think of those 1.4 million people using cannabis for medical purposes, not recreationally, for medical purposes, illegally, of course, in the UK, plus more than that who don't want to criminalize themselves, we're looking conservatively at about 2 million people plus who would benefit from this medicine. And so far, National Health Service has 3 prescribed. So there's 1,999,997 people more to prescribe on the NHS. So we have not yet succeeded in getting this medicine available is an understatement.
Mm.
And where does that number come from, Mike? 2 million? I didn't quite follow that.
1.4 million is a general. That was a survey done 2 or 3 years ago now. I think it was originally done by the United Patients Alliance. It's a figure that's been sort of verified. It's obviously, if it's an illegal market, you can't ever guarantee that figure. But I think it's generally accepted as about 1.4 million people using cannabis medically, and then to which you need to add those who would benefit from it with pain or anxiety or epilepsy, who don't wish to use it illegally at the moment. The figures roughly, you could say 2%. If you look at the countries where it's legal, very crudely, 2% of the population benefit from cannabis prescription. So if we have a population of 66 million in this country, you can comfortably multiply that by 2. So the figures, give or take, 1.5 to 2 million would benefit from this medicine.
Thank you. Great. Bradley, would you like to say something at this point about the change since for patients since UK law changed? Do you have?
Yeah, well, I don't think it's the Canadian in the room. I'm qualified to talk on the NHS system. What I can tell you is, like, for example, I think statistically Mike's numbers are pretty much spot on, even when we look at Canada. So, for example, in Q1 this year, we had 329,000 Canadians as registered medical cannabis patients. But when you actually look at the surveying around that, you can get a prescription, you can have a cultivation at home for a certain amount of plants, but the vast majority of people are still using off the books illegal cannabis. And the real question about that is why, right? And so there's a cost factor structure in there, but there's also a relevancy of, for example, and I'll give this example. Last year, Q4, I got diagnosed after a colonoscopy with cancer, and I had to go through, 27 chemo treatments and 27 radiation treatments. And at the end of that, if you think that I wanted to like to add something for my post-treatment recovery that wasn't opioid based, I would have been delighted. The problem was finding somebody who could help me with that in Canada, in Vancouver, which is very, I'd probably say more open to it. And then the other thing is their knowledge base. And there's a lack of information, and the lack of, from my perspective, a lack of data. Lack of data drives lack of meaningful regulations. And I think what I'm hearing from both sides on the other side of the ocean there is that's the same thing in the UK as it's happening in Canada, right? So people do what they do, they'll try to figure it out themselves. And that can have, especially if you're looking at somebody who has a mom who's in the suburbs, a child with epilepsy, I couldn't imagine them trying to take something, put into their system. You know what, honestly, for what I was dealing with primarily the relief of pain for radiation burns, I couldn't sit down long enough to do the homework or the research, let alone to try to figure out. And there was, whether I went and bought it at a legal dispensary, because we have legal dispensaries over here, which are non-medical, or I went and I signed up for the Canadian Health Program, the information, what people knew, was no different. And that's the problem. The person behind the counter or the person prescribing are giving me the exact same things. One might be covered by my health insurance, a private health insurance, and one is out of pockets. And I think for the way we perceive it, that's the biggest problem. It's information.
Mm.
Yeah.
And do you think there's a difference in the medical profession's openness to prescribe cannabis then, or acceptance of cannabis as a medicine in Canada to the situation in the UK? I mean, we all have the same data, don't we?
Well, we all have the same lack of data, and I think that's probably what we can all probably agree upon. I mean, look, there's a fundamental problem we're dealing with a plant, right? And there's a lot of variances in there, and we only know what, and once again, I'm going to stand to the experts on these things. I'm just the data guy. We deal with the construct of what we're given. But if we know what a certain percentage of the product does to our body, we know the other parts impact it. That's still not enough unless you have a full data stream, almost on a per gram basis, like on a consumer to per gram basis. And so I can tell you from, I've always been a big patient advocate. And when you become the patient, it changes your perspective. It takes you one direction or the other direction. And one of the things that I found is, I went to British Columbia Cancer Clinic, and I asked them, I said, what do you think? I'm going to defer to the experts. You know what their answer was, Brad? We just can't tell you. We don't know what to tell you. But we can tell you that morphine will do this for you. We can tell you that these three other things will do this for you. And in lieu of trying to figure out, I put it this way, I couldn't imagine a parent, and I'm a parent, having to deal with that situation, even as a patient, going through it and thinking, well, what if I have a seizure? Pack that on top? No thanks, right? And I think that's with what Mike and Dr. Moore are saying. It's the exact same thing. Like people, there's if it's happening in Canada, guarantee a version of it's happening in the UK as it's happening in any state in the United States, as it's happening in Israel, or it's happening anywhere in the EU. And I think when the EU came out in 2019 in Q4 or 2018 Q4 and said, we need to take it off Schedule 1. And there was a big but we need more information. And that's, to me, I haven't seen a lot of progress from those, but we need more information.
Okay. Becca, have you noticed a change in the profession then since 2018? What's happened in the medical profession? Are attitudes changing?
I think they are changing, but I think I would say they're still very mixed. And I think, you know, a lot of people are really interested and really curious about this and want to learn more. Whether that means they'll end up prescribing, possibly not. But I think people are starting to really recognise that this is something that can be hugely helpful, that we're gathering more data. We have projects like Project 21, which is going to give us a huge amount of data to learn from. And, you know, I taught 500 GPs recently, and over half of them said that they wanted to prescribe, but weren't able to for some of the processes that we've already, you know, described. So I think there's a lot of interest there for people who want to learn more and to prescribe. And I think also, you know, certainly in the UK and I'm sure in Canada, this is an area where the patient voices are so powerful. And I think they are driving change as well. And I think that's brilliant because, you know, we neglect their stories and their expertise at our peril, would be my view.
Thank you. Thanks. So, Mike, coming at the same question from a slightly different angle, why do you think the guidelines from the RCP and the pediatric neurologists, I can't remember the word you used to describe them, but you know, you think they're overly cautious or too strict? Why? I mean, why is that the case?
I think the fundamental reason was a little bit of 2 or 3 reasons. I think the stigma around cannabis hasn't permeated to the higher echelons of the medical profession. I think that's one. But I think the main reason is actually that those bodies that have produced guidelines have looked at cannabis as a pharmaceutical product. And they're wanting it to jump through the pharmaceutical hoops. They want it to go through double-blind placebo-controlled studies. And they are just totally inappropriate for a plant. It doesn't work that way. Unless you take isolates, then you compare an isolate, say CBD, with a placebo. But then you miss out what I don't think can be argued now scientifically about the entourage effect, which means the whole plant is better than the sum of the individual components of the plant. So the whole plant works better. I don't think there's any doubt at all about that. And of course, if you look at a whole plant with 140 plus cannabinoids and 100 plus terpenes, let alone flavonoids, you can't, in all honesty, conduct a double-blind placebo-controlled study like you can with a single molecule pharmaceutical product. It just doesn't work. So what you've got to do is look at what is now fashionably called real-world evidence. That's actually what it really does to the patient. And there's a huge amount of data on observational studies, case studies, case control studies, N of 1 studies. All of a sudden, of course, with COVID, real-world data is finding some sort of traction and is meaningful. And looking at the vaccines, people are looking at real-world data and think, oh, this is fine. But when it comes to something like cannabis, then, of course, it's not fine. And we still have to put it back into a pharmaceutical box. And cannabis does not fit into a pharmaceutical box. NICE may be constrained by their own regulations, I don't know. But for whatever reason, they looked at it as a pharmaceutical product. And if you look at it, okay, how many double-blind placebo-controlled studies have you got for one cannabis with pain? The answer is very few. And if you look at it from that parameter, I totally agree with the guidelines. There's not enough evidence on that basis. But if you look at the real-world basis, there is overwhelming evidence, not for everything. I'm not one of these people who says cannabis is a cure-all for every known disease to man in any remote sense. But for certain indications, there's a lot of hard evidence behind it. And that's what these bodies don't recognize or don't want to recognize.
I mean, we have to be very careful of observational evidence, don't we? I mean, it's prone to all kinds of bias and flaw.
Yeah, but you're in danger of going down a pharmaceutical route, Richard, because you shouldn't forget that there's something like 165 million people who use cannabis every day in this world. And that's a huge amount of safety data. You know, somebody at the Health Select Committee about 18 months ago said this might be the next thalidomide. Well, complete and utter rubbish. You know, millions of people have used it for thousands of years, and we would know if it was the next thalidomide. So a doctor's concern has got to be, A, safety. And I don't think there's any doubt on any parameter that cannabis is a safe medicine. It doesn't kill people, unlike opioids. The other parameter then doctors need to look at is whether it works. And we know it works on a real world basis for a lot of conditions, for a lot of people, not everybody. Something like 80% of people you prescribe it for pain will have a pain-killing effect. Something like 80% plus of those who use it for epilepsy has a very useful anticonvulsant effect. So we know it's working. We know it's safe. And we've got to remember also that we're not suggesting it's a first line for anything. We're looking at people who have reached the end of the road for, let's take pain medication. Nothing else is used. Epilepsy, they've used every anticonvulsant there is. Nothing else is working. And in that situation, I think it's verging on the immoral not to try something that we know is safe and we know works, or because it hasn't jumped through a pharmaceutical double-blind placebo-controlled study. We need more evidence. I'm not saying we've finished evidence. We need more evidence, but for heaven's sake, let's use it for those who are suffering at the moment now with their pain or their anxiety or their epilepsy. That's my view, and I can't think, when you think about it, that intellectually there's much argument about that. There clearly is, but I don't understand the arguments against that.
Thank you. Bradley, do you want to say anything more about data and evidence? Does that relate to to your interest, to what your company does?
Yeah, no, I think Mike nailed it, right? I think, I mean, the facts are undeniable, and I think you come out with a good question about the perception or the construct that somebody answering a question and how they answer it, or the environment in which they answer it, means is truthful or not, right? I mean, if you're sitting in a clinical study, I have just much propensity to lie to you about how I'm feeling versus having a conversation with Mike. And obviously there's different controls. So it's the contract. When we sat down X amount of years ago now, and we said, okay, how is this breaking? Because I'm the kind of guy, I had a lot of investments in Canopy and Afria, and I was all excited. And I just said, hanging a neon green red cross and having some guy who's used it for 30 years and who has to have a lot of THC in his system to get, the next evolution is probably not the best thing if I'm walking in for the first time and I'm not feeling well and I want some advice. So it boils down to, kind of that aggregate data set. But you can't discount that guy's experience. The point is to understand him in context of that. We run by a very simple kind of theme in the company. And it's something like, I had the good fortune in 2018 spending 7 months, well, just about almost altogether in Israel, really digging into the Israeli model and how it worked. And I mean, it's so over controlled. I mean, you can't even look sideways without getting caught doing something. But they have the Volcani Institute, which is associated to the Israeli government. And so there's a lot of research and science going into it. And their program's actually older than the Canadian program. And, but at that point in time, they only had 29,000 patients, right? And so it was very strictly controlled. And so the short end of it is to understand what happens with a person when they use a specific product for a specific ailment at a given point in time under a set of circumstances. If we can get to that and capture that on a per thing and then layer that information over each other, then we can get to something we believe is averaged efficacy. And I use that term loosely and broadly, but if we can get to an average efficacy, then we can start to at least have spectrums that further doctors can say, well, there's a variance on either side. But as Mike said, and I'm sure we all agree, when you have a product, a plant with variations, this is why you have to start looking at good manufacturing process, or GACP. So for example, the president and the CEO of Cannabis investment arm said there's stricter controls for growing tobacco than there is in cannabis in North America. I mean, that's crazy. So, we all, on the package of tobacco, we say you're going to die. But in cannabis, we don't say what it will do for you. And there's a gap. There's a gap there on the manufacturer side, especially in North America or Canada. And there's a lack of accountability on these things. All you have to do is look. Canopy, the largest grower in the world, is under investigation for Health Canada by using averaged labeling. So they're saying that there's supposed to be a test for THC and CBD ratios, and now they're coming out and they're saying, well, everything is 20%. Well, it's not. It might be more, it might be less. That's a big problem. How, as a consumer, can you trust anything if it's not even accurately labeled? And I think that's it. So this
Yeah,
this is a
absolutely.
case of the growers wagging the dog, all of us on the other side of it. And I think that's a huge problem and something that we need to look at. So the construct of how do you get, and that's just the nature of the evolution of the industry, where it became more about money and less about patients. And I think, this is about the Brads of the world. It's about Becca's patients. It's about the people that Mike works with. It's about understanding what's happening, and you can't discount that. There are ways to self-monitor people. I mean, we happen to use the blockchain because, once you record it on there, you record it on there. It's not going anywhere. And if you have everything from a gram growing, every step of cultivation and a GAC process, and attach it to a consumption, at least it's a start point. And you start laying, like my objective is to measure 128 million grams over 2 years. That's, on average 300 grams a year. That's 400,000 patients. I mean, if we could pull that off, that would be the largest ongoing, perpetually cannabis type clinical study ever. And so the idea is there are tools, things, but Mike nailed it. You can't come at this the same way, because your start point is at the end point. Does it work for people? It's not at the beginning point. How's it formulated? Right? There's just basic common sense logic. It doesn't mean you can't come to a relative same conclusion, though. And I think that's where regulators fall down, right? And regulators fall down. Even was it 2 years ago, 3 years ago, even the head of the FDA in the United States said, we need to start listening to what people tell us more. And that's it.
Okay. Thank you, Bradley.
And we do need to regulate the industry. I agree. Just briefly, and this is an unlicensed medicine, and I think the producers have an obligation to make the product as good and as safe and as well labeled and as with proper certificates analysis they possibly can. And some of the producers are letting the side down, if you like. We need much better quality of product and information about that product. Absolutely, absolutely right.
We give regulators the data, meaningful data, then they can regulate effectively and hold the guys. And at the same time, if we have enough data, then we can create a feedback. Like we do something called seed to seed, not seed to sales, seed to seed, all the way back, consumption all the way back. The idea and the construct behind that is if we're pushing information back to the grower, they want to sell more stuff. They want to sell it. So they need the feedback. And there's ways to do it that don't break HIPAA compliance or GDPR standards. Point around it is the answer all lays in data. We just have to get our heads wrapped around it's okay to come at this problem from a different way. And you know what? Maybe thankfully, because it is cannabis, it's not truly, it's medicinal in nature, but it's not a regular, it's not medicine per se, as Mike said, because there's no formulation. This is the opportunity to actually do it and start to move ourselves towards more personalized medical paths.
Becca, are you involved in research is your clinic involved in any research?
They're starting to be. I think, they're starting to gather data, certainly looking at outcomes, for people going through the clinics. And one of my colleagues is looking at the potential role of medicinal cannabis for those with long COVID. So there's definitely lots of people, starting to think about research. And, we see people that are registered with Project 21 as well as part of the clinic. So obviously they are being, part of a huge data set.
Sorry, you mentioned Project 21 before, and it's drug science, isn't it, David Nutt's project? But could you just say a little bit more about that?
So it's a data.
Explain what it is.
Yeah, of course. So people can register in it that have certain diagnoses, so anxiety, PTSD, ADHD, pain, and then they go through a program where they have regular follow-ups, regular screening. It tracks their response at 1 month, 3 months, 6 months, 9 months with standardized scores and scales, which are pulled out from their original assessment. So it identifies which might be the best scores to be tracking them on. Things like quality of life, sleep, a whole host of really global outcomes. And then also, for the patient perspective, it means that they can access some of the products at a slightly reduced rate in terms of costs. So it's really great for people as well that would otherwise be excluded from accessing this as a treatment for themselves.
Yeah, there's 900 people on the T21 program now, so even that in itself is a good quantity of data. And obviously, by the means of the title 2021, the aim was to get to 20,000 patients. They won't at the end of this year, but it's a major undertaking and will produce some really interesting, meaningful, long-term data. So I think it's a great project.
Are you involved in research or data collection, Mike?
Well, I'm the clinical director of T21 now, so I'm involved in that research. I used to be involved a long time ago with Sativex in the very, very early days. Sativex was for those who don't know, was the first licensed cannabis medicine, which is a combination of CBD and THC, licensed for spasticity and MS, made by GW Pharma. So I was involved with that right at the beginning. That was perhaps 20 years ago, but not more recently till the T21 project. I moved into other areas of research.
Great. Mike, what needs to happen next then? What should happen to help the patients who would benefit from access to medical cannabis? Is it more legal change? Is it a shift in the profession? Is it just about collecting more data? What needs to happen, and how can that
I think several things needs to happen. Actually, the law is actually quite liberal in the UK, and I don't have any great problem with that. A doctor can prescribe for any condition for which he or she thinks there is the best interest of that patient. So that's good. I think the only regulation change I would like to see is to allow general practitioners to prescribe. I think GPs, if I might perhaps oversimplify to an extent, will be very good cannabis providers. They tend to be a little more holistic than many of my consultant specialists. They clearly know the patient and the family. They know the nuances of that family dynamics. I think that's all important when you're dealing with symptoms. And of course, many of the things that cannabis is good for, like anxiety and pain, are things that generally, until you get to the very severe end of the spectrum, fall within the GP parameters. So I think opening up prescription to GPs will be really useful. I think, other than that, it comes down to education. And there's a lot of ignorance, a lot of misinformation amongst my medical colleagues. And I think teaching doctors, even if they don't want to prescribe, just so they can make a sensible decision whether this is right for you. I don't want to prescribe, but I know someone who can. I'm not suggesting every doctor should be prescribed, but of course not. That would be silly. But I think we need good quality educational programs so that the doctors can learn about it, know that it is safe, know how to deal with it, because it's a plant, and a lot of doctors don't understand what to do with a plant, let alone vaping, for example. I mean, how many doctors have been taught about flower and vaping, and 60% of the prescriptions are for vape? So I think I would put the priorities as number one, education. I think Tony Blair said that, didn't he? Education, education, and education. So when you get down to number 4, let's get GPs to prescribe. And I think if we put those things together, we'll be in a better place.
And you're involved in some activities to improve clinicians' education, I think. Is that right? What else needs to happen? Who should be leading on this?
The trouble is, when this country, the education of doctors falls to the doctor community itself. There's not a sort of formal governmental body that can do it very readily. So at the moment, we set up the Medical Cannabis Clinicians Society when the law changed in November 18. We've now got over 200 members. And by definition, they're clinicians and not all doctors, so pharmacists and some nurses, but mainly they're potentially prescribing doctors. So having that peer support system is really useful. Because, you can teach someone the basics in a day's course, sure, but then it's more important for mentoring of those doctors and someone to ask questions of and someone to carry on the supporting. Many of the clinics do that themselves, but the society also does that. So I'd like to see not just better training, and the society does training, There's the Academy of Medical Cannabis. Now Drug Science does a monthly training session as well, and I've trained about 100 doctors now. It doesn't have to be all me, but that's the case. So I'd like to see.
They still aren't prescribing.
Some have come on that course. Well, there's 60 as of yesterday. There was 61 prescribing doctors in the UK, and I've taught about 100. So some come onto the course quite rightly and totally great. They want to learn more about it, but they don't want to prescribe. And some are waiting to prescribe. I think we'll be up to about 100 doctors prescribing by the summer. When you think about it, you don't need that many more than that. If you've got in every locality one expert prescribing cannabis physician and other doctors educated to know when it might benefit people who can then refer to that local cannabis physician, I think we've resolved the problem. So I think probably 200 prescribing doctors in the UK, 1 or 2 for every hospital trust or CCG would be enough to cover the needs of many of the people in this country.
Thanks, Mike. Becca, do you want to say anything about education? I think we have about 5 minutes left. So if you have anything to say on education, and then I'll get some final words from you all, that would be great. Thank you.
Yeah, I mean, I agree with what Mike said. I mean, I'd like to see more thought about this, even in medical school. You know, more discussion about this as an emerging field of medicine. You know, to be really talking about this. And I think I'd also say, you know, as one of the early prescribers, you know, it was so important to have a clear network of people around us, because it actually felt quite frightening to be one of the first prescribers, because, you know, there are a lot of colleagues who are not sympathetic at all, and indeed quite critical. So, you know, it did feel quite a thing to be one of the first prescribers. And, you know, what has kept me prescribing has been seeing the effects of people, which have been life-changing in many, many cases. But I absolutely agree that education is key. And I think, you know, that makes a huge difference.
And in just final words from you all, do you have anything else to add, Becca, that you'd like to talk about now, or summing up?
I think, you know, my take home is that I would just like anybody watching to get curious about this, to learn a bit more about it. Whether you want to be a prescriber or not is not actually the issue, but actually there is a lot to be learned from, you know, thinking about medicinal cannabis, thinking about how it's prescribed. And I think, you know, it really is a great choice for many, many people that we work with and support that have complex and chronic conditions where there's an interplay of pain and mental health, particularly. So I think just stay curious and open to it, even if you know you don't want to be a prescriber.
Bradley, do you have any closing words?
Yeah, I mean, first of all, it was a great discussion. It's interesting to hear from the other side, you know, sitting over here in Western Canada, what's happening in the UK. Look, I think it's a multi-dimensional problem. It's not linear. It doesn't start at one point and goes forward. There's attack points. You know, one of the big things we're doing is we've applied for a non-possession selling license to put ourselves firmly between the manufacturer and the consumer, and we're going to educate the consumer. And we're going to say, if you don't know what this is, you shouldn't take it. Therefore, put pressure on the manufacturer. That's uniquely Canadian because of the way the system's set up over here. But at the end of the day, somebody still needs to get educated, right? Mm-hmm. And then if you put the demand, then you can start to create education over here. And we have to provide the tools. And we have to provide tools all the way across, from the consumer to the, whether it depends whether it's a pharmacist, whether it's a medical professional, all the way to the regulator. And so I believe the industry in itself, because if you're in Ottawa or London, you don't know any more what's happening than way less than a guy like Mike or Becca knows what's going on. So at the end of the day, we've all got to come together to provide this information, right? And then hopefully there's adoption, and it's just like all things, it's going to take time, but it needs to be consistently, you know, the point needs to be hammered home. And if consumers at one point say, hey, I'm going to use this, but you need to do a better job of telling me what's in it, then that will do a lot to pull things through all the way through. Patient advocacy is huge in this. It's huge.
Thank you, Bradley. Mike, do you have any final words? Just 1 minute now.
Yeah, I just would like to emphasize that, I'm not in any way, and none of us on the panel are saying in any way that cannabis is some sort of magic cure-all. If you go on the internet, some people do say that. They are wrong. It's just a very useful medicine for treating a lot of symptoms that otherwise medicine has let people down, in the sense that there's nothing else left. There's no more painkillers to try. There's no more anticonvulsants to try. There's no more anti-anxiety drugs or treatments to try. Everything has failed. We've got a good, safe medicine that doesn't work for everyone. It's not right for everyone. But for heaven's sake, it's there. It's good. It's useful for many people. Let's just get out and use it and learn as we go along. And that's what the doctors, I think, need to realize. It's safe. Learn as we go along, study what is a remarkable plant, and let's take it forward and use it as part of the normal medicine armory.
Great. Thank you so much. What a fascinating conversation. Thank you to Dr. Becca Moore, Professor Mike Barnes, Bradley Moore. Thank you all. Thank you to Cannabis Europa.